Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I am your host, Jonna Emil, and joining me again is Dr. Sally Miller. Dr. Miller, how are you?
I'm well, thank you. And you?
Not bad, not bad. Excited to hear another story. I like to play like a little nurse detective and try to figure out who done it and where do we go from here. So I am ready. I'm always really psyched and ready to hear these and to learn.
Okay. Well, this is a rather short story. There's actually one encounter between the APRN and the patient, and then there's another physician encounter, one or two phone calls, and the end of the story. So it begins with a 39-year-old woman. This 39-year-old woman presented to an OB/GYN practice for a same-day appointment for evaluation of her irregular bleeding. So this was the first time at this practice. She had another OB/GYN, and apparently she had had a well woman exam and a PAP 7 months prior to this. And why she didn't go back to them is unclear. We don't know why, but we know that she's here for a same day appointment. So the nature of the same day appointment is they're very focused. Most of us that see patients in primary care, you fill up your daily schedule and you leave a few holes in there for those calls you're going to get in the morning for patients that are acutely unwell. And then you can bring them right in. And these are short complaint focused visits. And that's the way it typically goes. So she somehow wound up at this practice for her same day appointment for an evaluation of irregular bleeding. So she comes in, she sees the nurse practitioner. The history of present illness reveals a very precise description of the pattern of normal and skipped cycles and the irregular bleeding and everything that's going on between 7 months ago and now. So we've got a good history of present illness about that. It's very focused on the irregular bleeding, as is the nature of a complaint-focused visit. The patient also requested that this nurse practitioner order thyroid levels for her because apparently she had a history of thyroid nodules and they were biopsied and they were normal, but the patient wanted thyroid studies and she asked the NP to order them. She did admit that she has an endocrinology appointment pending next month.
Okay.
So on a side note, the NP did order the thyroid studies for her and they turned out to be normal. But as we're critiquing things here, and just not critiquing is not the right word, as we're going through and just, taking a look at the trajectory of care, a real good takeaway point here is that we don't order labs unless they contribute to our diagnosis or treatment plan. Because if you order a lab and it's abnormal in some way, then the onus of responsibility is on you to do something about it. And, if you don't do endocrinology and you're not managing thyroid dysfunction, we really have no business ordering thyroid function tests. Now, if she thought that there might be an endocrine abnormality leading to the bleeding problem, well, then that's a different story. And she would have a plan based on that. But this is just, it is an interesting documentation. The moral of that side note is a lot of NPs are just too nice. We just can't be that nice. If the patient wants it, and this is what the patient said, I had these nodules. I'm going to see endocrine next month, but could you just order my thyroid test? I want to see what they are. The answer is no.
No, your endocrine can do that.
No, but that's not we don't just order stuff because somebody asks. We order things that are necessary to contribute to the diagnosis and treatment. As it happens, that particular thing has nothing to do with anything else that happened, but it's that kind of thing can blow up in your face. So when people ask you to order a thing, you really don't want to order it unless there's a good reason for you to do so. Okay, back to the story here. So now she's, being seen here because of her abnormal bleeding. And she goes on to report that her last GYN exam was 7 months ago and that it was all normal. The patient goes on to give, she fills out her history form and then the MP is looking over it. She goes on to review her menstrual history, gynecological history, sexual history, her medication. She's on a few different things. review of systems, and the family history notes that her sister died of breast cancer.
Oh,
And that's documented in the history. So then the MP goes on to do a physical examination for this complaint-focused visit, and she documents a detailed examination of the internal and external reproductive anatomy of the genitalia, the history and physical findings that led to this diagnosis, like a very complaint-focused thing. She's here for her irregular bleeding, so there's a very detailed history of her bleeding patterns and any coincident medical conditions. What medications do you take? What, looking at the history. The physical examination is the pelvic exam, like it's the external genitalia and the pelvic exam. Again, very focused. Complaint appropriate counseling was documented, the potential causes of irregular bleeding, and some diagnostic studies were ordered, and that was that. The NP did document that she tried twice in the interview to get more information about the patient's sister's breast cancer, and that the patient didn't want to talk about it. The note didn't give all this detail. In her deposition, the NP said, I absolutely remember I tried on 2 different occasions to ask her more information about her sister, and she didn't want to talk about it. She said she was just there to talk about her bleeding.
Oh, okay.
The note did say that she assessed the family history and that the patient declined counseling, but that they didn't go into anything else about it. So that was the interaction. And NP, the patient, there were some laboratory tests that were done to evaluate for irregular bleeding, some other endocrine, like reproductive endocrinology and stuff. And the patient was advised to schedule a follow-up to come in and talk about her laboratory results. Well, 2 weeks later, the patient called the office to ask for her lab results, and she was told that she needed to make an appointment to come in, and she said she didn't want to. She didn't want to pay a copay to talk about her lab results.
Oh, geez.
So she was advised she needed another urinalysis. She was told to do that much, and otherwise she needed, to make an appointment. She didn't. She didn't make an appointment with the MP. She came back about 3 weeks later for a different complaint-focused visit with the practice physician. She came in complaining of pelvic pain and back pain, and the physician evaluated her for that and ordered an ultrasound. And, again, it was a very complaint-focused visit. I don't think the physician's note addressed family history or breasts in any way. It was very focused to her back and pelvic pain. The only other contact was by telephone when the patient had an ultrasound following her visit with the physician. And the physician advised that she go through another entire menstrual cycle, and then at a very specific time in the cycle, have her next ultrasound, because that's when they could best visualize the ovaries and be looking for if there's a ovarian cyst. That was the leading differential.
Okay.
So she was advised of that. She was advised to repeat the ultrasound and then make a follow-up. A referral slip was left for her at the front desk. She never picked it up. She never repeated the UA. She never did her ultrasound again. The practice reached out to her 2 months later to encourage her to do the ultrasound, and she never did. And the next contact was a year and 2 months later, when the patient contacted the practice to advise that she had breast cancer and that she felt she was underdiagnosed during her encounter of 14 months previously. So that's the story. So there was, a plaintiff's witness looked over things, and essentially the allegation against the nurse practitioner was that there were a number of negligent acts and omissions, and that the NP failed to order or prescribe a screening mammogram or other breast health screening test or exam, failed to order or prescribe breast ultrasound, CT, or MRI, failed to order or prescribe ultrasound-guided biopsies of the breast, failed to refer the patient to an oncologist for evaluation, failed to order or prescribe genetic screening or genetic testing, failed to perform a clinical breast examination, failed to conduct any other breast cancer risk assessment, failed to intervene to protect injury to the patient, and failed to properly supervise staff in the office like the people that, were advising her to come back and pick up her thing and stuff like that. And then the last one was otherwise acting negligently and carelessly as more discovery may reveal.
When in the world would the NP have done? So you're going to breast biopsy me when I tell you that my sister has a history of breast cancer? You're going to do a biopsy of my breast in that moment?
It's just, or order an MRI or an ultra or anything. Like it really is ludicrous. Again, it's just an example of throwing everything out there, throw out the net and hope that you can catch something. So now I'm looking directly at the chart here, not my summary of it. And, again, it's irregular bleeding is the chief complaint. The history of present illness goes on to enumerate, like for the last 7 months, when there was a cycle, when there wasn't, how long this one was, that the patient wants the thyroid done, that the thyroid biopsy was normal, but she's still going to endocrine, that she had a normal Pap 7 months ago. She did have a culture positive, like there's this for bacterial vaginosis. There is this long thing, and there is patient has a sister dead, or sister, dead, check off, it's like a checklist thing here, various family members, sister dead, reason breast cancer, and then history, breast cancer. So she clearly discussed the breast cancer. At the end of the visit, she documents her, irregular bleeding, or I'm looking for exactly how she put it. Yeah, sister, cause of death, breast cancer. Oh God, this is a long note. All these click and pick notes are so long now. And again, the exam of the genitalia was very detailed because that's why she was there.
Right.
Okay. Diagnoses, irregular menstruation, unspecified. Because that's all there is at this point. Because, when you have to assign an ICD-10 code, if you have a diagnosis, you make one. And if you don't have a diagnosis yet, you code the symptom or the various symptoms. And so she had some thought processes about why the patient's cycles were irregular, but no answers yet. So actually, this is really a very appropriate ICD-10 code. Menstruation is irregular. And then a series of tests were ordered. Prolactin, serum HCG, which is, of course, a must-do, CBC with differential, FSH, TSH, the usual suspects when you're trying to evaluate causes of an irregular bleed. And then in the counseling, there's a counseling section of the note, which is what we would think of for patient education, the education piece of the visit, and everything that was reviewed, and then 2 attempts to explore the family history of breast cancer. Patient was non-responsive. So, I really think any thinking person would realize that if the patient won't discuss risk factors of breast cancer, that she's probably not going to have a breast exam today.
Yeah.
But it would have been helpful to write that, again, pertinent negatives.
Yes.
Would be a good idea. I mean, the patient was 39, and there is no routine recommendation for doing screening mammography on a 39-year-old.
Right.
Now, there is a recommendation to begin breast cancer screening 10 years prior to the age of onset of a first-degree relative. So, but we don't even know how old her sister was because she wouldn't talk about her sister.
Right.
So we don't know when her sister was diagnosed with breast cancer. So to blanketly say, oh, because her sister had breast cancer, she should have done one too. Her sister could have been 20 years older than she is. Like, I mean, that stuff really isn't that unusual. We just don't know. And then, of course, somebody else would say, well, Sally, you're slanting this the way you want to see it. Her sister probably was younger. But probably one way or the other, they're just not relevant, really, when it comes down to reading the chart.
Fact, right?
Reviewing what's there.
Don't know.
And the other thing that we always have to keep in mind is that when the documentation, it would have been helpful if it was more specific about how we tried to pursue this family history and were rebutted into it.
Yeah.
I mean, as I read the note, I can totally visualize what happened here. When you read some of the other, like some other things that were in the patient's chart, so, the MP says, I will see the patient back when diagnostic testing is completed. So then the next thing that you see, I want to read these to you verbatim here. Somebody blank useless pages in medical records these days. Okay. The patient calls asking for the results of her labs. And, that's when she's told she needs to make a follow-up appointment so that she can come in and talk about her labs. And she says, she's not coming. I'm going to give you the exact word for word. She doesn't want to pay a copay to talk to somebody that doesn't know what it was something like that doesn't know what they're talking about.
Oh my gosh.
I'm going to find it for you. It might be tomorrow before I find it, but I want to read you anyway, the gist was she was not happy with the NP, more likely just not happy with the fact that it was an NP, even though the NP note was really much more detailed given a complaint-focused visit. Like the NP elicited the smoking history and the physician said she never smoked. Just checked off no.
Right. Would this have been one of like the cases that like, for instance, it's like an AMA kind of thing. I'm trying to examine the breast. I'm trying to talk to you about your breast. And like, this is a risk factor and you don't want to talk about it. You don't want to let me examine it. So I need to document that. This I recognize as a provider is really important for us to talk about. You don't want to. I'm going to document that you don't want to, but you should because of XYZ.
And it really is helpful to document that, how aggressively, it doesn't have to be all day. You don't have to write like War and Peace, but you do really want to document that you've emphasized this. The patient called with the following message. Patient states she does not want to come in and pay a copay. Results, which reveal abnormalities and recommends an MRI. Patients, like that's the result. She doesn't want to come in and discuss that. Patient states she wants results from the doctor. She does not, and this is all capitalized, she does not want, quote, anyone who is not qualified to give results to call her.
Oh.
So listen, the patient has every right to refuse to be seen by anybody. She has every right to that. But you do get a vibe here of an approach to the healthcare system. Further, she never did come back to repeat her urine. She never went on to repeat the very precise ultrasound recommendation that was given by the physician. And she didn't remember that she said she didn't know she had to repeat it. And then when she was shown like, hey, like, see this note, they actually called you 2 months later, and she didn't remember any of that. So it really does give the impression of someone who knows very much what she wants and doesn't want what she doesn't want. And it's just really hard to imagine that she would have been amenable to any sort of breast assessment, even further questioning about her own breast health. I mean, it's not just a mammogram. It starts with her own history. Has she had any history of tenderness, pain, lumps, any discharge, skin changes? Do these things occur? Like, do they come and go? Do they change with the cycle? She didn't want to talk about any of that, much less have someone do a breast exam in the office and diagnostic testing. I mean, she wanted her thyroid test. So I am drawing some conclusions here, and I guess I'm opining a little bit. But as a clinician, I'll bet everybody who's listening can identify with a patient under these circumstances. And it's unfortunate because there was a settlement here too.
Was there?
Unfortunately, there could have been better documentation about if there's a first degree relative with breast cancer. It could have been more clearly articulated what an effort was made to impress upon the patient her risk and what we would offer her to try to assess for or minimize it.
Oh, man. And did they bring in, because I'm thinking about the fact that you said that she had a PAP 7 months before seeing this NP. Was that provider also brought into this?
No, in fact, that's who she went back to. That's who wound up actually, I guess she found a lump. Like, all these months later, she developed a lump, and then she went back to that first one, and then they're the ones that worked it up and found the malignancy.
Oh, man. So the NP then, in this case, was named, not the physician.
Yeah, he was too.
Oh, he was too.
He
wow.
was too.
Oh, my gosh.
Like I said, they'll name everybody. And it's really, it's just about whose attorney is the better debater.
Yeah.
What precedent is in that jurisdiction. And, it's like sometimes there are clear cut deviations from standard of care, but deposition testimony is sworn testimony, and it's accepted as true. I mean, it's considered truthful testimony if somebody testifies to something. And in the deposition, the NP said, yeah, I know I didn't write it all down, but I do remember her. Because of course, when you then get a call or you find out that a patient you saw has a really bad outcome, you do tend to remember it, and you go back through the chart and look and think, did I miss something? So she remembered the patient, and she said she clearly remembered that this patient didn't want to talk about anything except her irregular bleeding. She wanted to talk about that, and she was a bit difficult about it. And I totally get how that is. And we can't tie somebody down and make them have a breast exam or make them answer your questions. And most of us would recognize that almost certainly she wouldn't have been responsive to that. But it really helps if it's written down that way.
That stinks. I mean, sorry for the patient, obviously. That stinks. Yeah. That stings a lot.
Just something as simple as in the note, advise patient strongly, we should explore breast family history, breast health, breast issues, patient declines, further history, examination, etc. Just a couple of sentences would tell everyone that's what happened.
Wow. And, can I ask a quick clinical question? Is there any correlation between abnormal bleeding and breast cancer? Like, would there have been any reason for someone to have been extra alarmed that this is not just a weird kind of cycle, but there's a connection here, maybe?
I'm really not sure, to tell you the truth. Intuitively, I would think so, just because there's a hormonal thing.
Yeah.
There's a hormonal relationship going on, and the hormonal abnormalities, breast cancer, most of them anyway, are estrogen-fed cancers. Yeah. And if there's an abnormality in estrogen production or secretion, that would also produce an abnormality of menstruation. But that's not, again, that's not my area of expertise, but it is, I have the benefit of hindsight, but I can tell you if I ever see anybody
you're thinking it now.
Abnormal periods. We're totally thinking it now. But I could definitely see that there's a hormonal articulation. Although, it certainly isn't the first thing that comes to mind, except in the case of a first degree relative.
Yeah. Which is so important. So important. Again, documentation is so important, and important to write down. Even the nose, when
the pertinent negatives, Like, you don't have to say, oh, the head is normocephalic and the sclera are anecteric, but the pertinent stuff.
Yeah, absolutely. Thank you, Dr. Miller, for this story. Appreciate you sharing this. As always, such a great opportunity to learn. And thank you all for tuning in and listening. We hope you enjoyed. And if you'd like to listen to more, check us out on FHA.com. We got lots of Scrubs Subpoenas there, or anywhere that you like to listen to your favorite podcasts. And until next time, goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.
Thank you.